Hello everyone. Today we'll discuss about the median nerve injury. Before knowing the clinical presentation according to the level of median nerve injury, first of all let us understand the course of the median nerve. This we already know from the anatomy. The median nerve is derived from the medial and lateral cord of the brachial plexus. So it comes from the medial and the lateral cord of the brachial plexus. Its root value is C6 to T1. It also contains fiber from C5 in some individuals. Then it travels down the medial side of the arm and enters the cubital fossa. From the cubital fossa, it branches and gives the supply to the pronator teres muscle, which is the muscle of the flexor compartment of the forearm. It also branches in the cubital fossa to give to flexor carpi radialis and also the palmaris longus. Then it travels downward through the cubital fossa and enters the anterior compartment of the forearm. Here it branches in and gives supply to the flexor digitorum superficialis, and then it branches into anterior interosseous nerve, and then it continues towards the wrist. So once it reaches the wrist, it enters the cubital fossa and then again branches into the sensory and the motor branch. So the motor branch will supply to the thenar muscles, which is called as recurrent branch, that is recurrent thenar motor branch. It supplies to the thenar muscles as well as to the lateral two lumbricals. Then the sensory branch gives rise to the palmar cutaneous branch, which innervates the lateral aspect of the palm, and the digital cutaneous branch, which innervates the lateral 3.5 fingers on the anterior or palmar surface of the hand. You can see in the picture, this is the lateral 1, 2, 3 and half. The blue area which you can see, that is the sensory supply, the palmar lateral 3.5 digits with the palmar surface, and the medial aspect of the thumb, the posterior aspect of the index and the middle finger until the proximal interphalangeal joint, and the lateral aspect of the index finger until proximal interphalangeal joint. So once we have known the course of the nerve, then we can predict the level of injury. If the level of injury is above the elbow joint, that is at the area of distal part of the humerus or supracondylar area, then the overall function of the median nerve may be involved. For example, supracondylar fracture causing the median nerve injury. In this kind of condition, overall function of the median nerve may be lost. If the level of injury is at the level of proximal forearm, then the pronator teres, flexor carpi radialis, and palmaris longus may be spared, and the other functions below distal to this injury will be lost. If the level of injury is at the wrist joint, that is at the carpal tunnel area, then the functions of the median nerve supply to the thenar muscles and the sensory supply to the lateral aspect of the palm will be lost, whereas function of the anterior interosseous nerve supplying to flexor digitorum profundus, flexor pollicis longus, pronator quadratus, and branching of median nerve proximal to that, which is flexor digitorum superficialis, palmaris longus, flexor carpi radialis, and pronator teres supplies will be intact. The main causes which are responsible for median nerve injury are the crutch compression at the level of axilla or anterior shoulder dislocation. At the upper arm, it could be stab injury, any penetrating injury, fracture of the humerus, shaft of the humerus, fracture head of the humerus, etc. At the level of elbow, the most common cause is the supracondylar fracture of the humerus. It could also cause by elbow dislocation or injection injury. Pronator teres syndrome is one of the main cause at the level of elbow, and at the level of wrist, carpal tunnel syndrome is one of the important cause. So these two topics are important: carpal tunnel syndrome and pronator teres syndrome. So let's discuss carpal tunnel syndrome. Carpal tunnel syndrome is the compression of median nerve within the carpal tunnel. Some of the main causes for carpal tunnel syndrome are repetitive movement of the hand and the wrist, which causes friction of the nerve within the carpal tunnel, and there will be inflammation and injury of the nerve. Or it could be because of the hypertrophy of the muscles and the tendons within the carpal tunnel, causing compression of the median nerve. Examples are typing and swing. It could also be caused because of the carpal bone fracture or arthritis of the wrist. Some of the common causes are diabetes, obesity, or pregnancy. Infection of the wrist joint or any other structure within the carpal tunnel can cause compression of the median nerve. Rheumatoid arthritis or using of vibratory tools can cause carpal tunnel friction and compression. These are some of the postural problems which desk worker or computer workers usually come across. So the wrong posture of the wrists are too much of extension at the wrist joint, too much of flexion, excessive ulnar deviation, and radial deviation. So the normal posture of the wrist joint, which should be maintained to prevent carpal tunnel syndrome, is to keep the wrist in neutral position. That is, the axis of the forearms should be parallel to the axis of the hand, and there should not be any radial deviation or ulnar deviation. The hand should be parallel with the axis of the forearm. So this will prevent any compression of the nerve within the carpal tunnel. The signs and symptoms of carpal tunnel syndrome is numbness in the palm, thumb, index finger, middle finger, and lateral side of the ring finger. So we already know that the sensory supply of median nerve is towards the palmar aspect of the thumb, index finger, middle finger, lateral side of the ring finger. There also will be weakness of the grip. The weakness could be because of the weakness of the thinner muscles or because of the pain at the carpal tunnel. Tenal sign is mostly positive for carpal tunnel syndrome, that is, tapping over the median nerve at the wrist may cause pain which shoots towards the palmar aspects of the hand. Phalanx test is positive, that is, bending the wrist forward and holding it for 60 seconds. This may provoke the symptoms like tingling and numbness and pain. Other problems are with fine finger movements or coordination of the fingers and wasting of thinner muscles. Another syndrome which is important is the pronator teres syndrome. So pronator teres syndrome is the compression of the median nerve between the two heads of the pronator teres. Some of the causes for pronator teres syndrome are hypertrophy of the muscle, fibrous band within pronator teres, for example, in the occupation like carpentry. Repetitive motions of supination and pronation can cause compression of the median nerve within the pronator muscle. So, if you constantly supinate and pronate, the repeated contraction of the pronator teres can compress the median nerve. Bicipital aponeurosis, if it is thickened, it may cause compression of the median nerve within the pronator teres. Signs and symptoms are similar to carpal tunnel syndrome, with addition of pain and paresthesia over the forearm. And pronator teres test will be positive, where the patient will be asked to contract the pronator teres muscle while the therapist compresses the pronator teres muscle. This will cause pain, numbness over the forearm of the patient. Surgical procedure, which is decompression of the nerve by releasing the compression caused by the pronator teres, has shown 85 to 90% of positive results. Another rare syndrome is called as anterior interosseous nerve syndrome, or also called as Kilo-Nevin syndrome. This is a rare syndrome. It is the compression of the anterior interosseous nerve approximately 5 to 8 centimeter below lateral epicondyle. Anterior interosseous nerve will supply to the flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. So, involvement or compression of this nerve will cause only motor loss because this is purely a motor nerve. So, the supply to these three muscles will be lost. So, while we perform MMT, these three muscles MMT will be weak. It may be grade 4, grade 3, grade 2, etc. The common causes for this syndrome is fracture in proximal forearm, penetrating trauma, blunt injury, traction injury, etc. The clinical features are proximal volar forearm pain, paresis or paralysis of the three main muscles which are supplied by this nerve: pronator quadratus, flexor pollicis longus, and flexor digitorum profundus. Initially, there will be difficulty in performing movements, fatigue or clumsiness with writing, with fine pinch activities such as sewing, typing, etc. Deterioration of handwriting has been described as the classical presentation of anterior interosseous nerve palsy. So, the management of the median nerve, mainly the carpal tunnel syndrome, can be corrected by wrist and hand splint. Avoid sleeping on your wrist to prevent compression of the nerve in the carpal tunnel. Changes in workplace or the ergonomics, for example, drawer should be at the optimal height, cushion mouse pad should be used, keyboard should be low enough so that your wrists aren't bent upward while typing. Low intensity laser has shown positive results in reducing pain and inflammation of the median nerve. Stretching and strengthening exercises should be given to improve the strength of the muscles which has lost its strength. Nerve gliding exercises are some of the important exercises to prevent compression of the median nerve at the pronator teres or carpal tunnel area. Nerve gliding techniques for reducing compression of the median nerve at carpal tunnel area. So it is very simple. Patient just needs to extend and flex the wrist while the arm is flexed to 90 degree. Surgical procedure for carpal tunnel is the carpal tunnel release, where the carpal transverse ligament is cut to ease the pressure on the median nerve. This type of surgical procedure has shown positive results if the conservative management fails. Other common managements for median nerve injury can be gentle passive range of motion activities to prevent any stiffness. Icing and compression can reduce swelling and inflammation. Modalities and medications for inflammation, pain, and swelling can be administered. Gentle median nerve gliding, which we have already discussed. Soft tissue mobilization and massage can help reduce fibrosis between the muscle and the nerve. So, to strengthen the muscles supplied by the median nerve, I have one video demonstration that is for flexor carpi radialis. So, if the muscle grade is more than 3 plus, we can apply resistance, and for hand and wrist muscles, manual resistance has shown better results than using any kind of other resistance equipments. So here you can see patient is asked to flex and radially deviate, and then the therapist will apply the resistance against this movement. We can ask the patient to repeat this 10 repetitions into 3 sets. And as the strength improves, our resistance also should be increased for progressive resistance exercise. So from median nerve injury, carpal tunnel syndrome and pronator teres syndrome are some of the important topics.